Staging of the mediastinum in non-small cell lung cancers. In some cancers, we use procedures additional to imaging for the most appropriate staging. For example, in a patient with carcinoma stomach, we would ask for a staging laparoscopy before the commencement of any therapy to rule out peritoneal disease, which is CT or a PET occult. Very similarly, for the most accurate staging of non-small cell lung cancers, our ultimate aim is to stage the mediastinum, that is, the presence or absence of metastatic lymph nodes in the mediastinum. Because this changes everything, this changes our treatment intent and the treatment modalities. So, the lymph nodes that we are talking about, the mediastinal lymph nodes, are numbered as per stations. The upper, middle, and lower paratracheal lymph nodes, the upper and lower on right and left are called station 2 and station 4, R and L. And here in front of the trachea, we have the great vessels crossing. So the lymph nodes in front of the eye vessels will be called as prevascular, and the lymph nodes posterior to the trachea are called as retrotracheal. And then we have the subcarinal lymph nodes, the paraesophageal lymph nodes, and the pulmonary ligament lymph nodes, that is station 9. So this will be the pulmonary ligament, which is the inferior border of the pulmonary hilum. So that will be station 9 lymph nodes. Station 10 onwards are N1 lymph nodes that are in the lung parenchyma, on the hilum, the interlobar, lobar segmental, and subsegmental. So stations 5 and 6 warrant special mention because they are in unique locations. Station 5 being subaortic and station 6 is paraortic lymph nodes. So these are the prevascular and the prevascular and the retrotracheal lymph nodes that we saw earlier. So stations 10, 11, 12, 13, and 14 are called as N1 lymph nodes because they are associated with the lung, whereas N2 lymph nodes or the mediastinal lymph nodes would be stations 2, 3, 4, 5, and 6, the subaortic and paraortic. Station 7, the subcarinal, the paraesophageal lymph node, or the station 8, and the pulmonary ligament lymph nodes, or the station 9 lymph nodes. So stations 2 to 9 are called as mediastinal lymph nodes or N2 lymph nodes. Our ultimate aim in doing this mediastinal staging is to know whether a patient has N2 or N3 lymph nodes. N3 is contralateral mediastinal or supraclavicular lymph node. Contralateral as in oncological midline of the mediastinum is not bang in the midline. It's in the left border of the trachea. So the left paratracheal border is the oncological midline of the mediastinum. For example, a patient with a left upper lobe tumor with a 4R lymph node or a station 8 lymph node on the right side of the oncological midline would mean that the patient has a contralateral mediastinal involvement that would quantify as N3. So, why are we so meticulous about this? Why do we have to be so meticulous about this mediastinal staging? For example, these are four spectrums of patients. In this patient, wherever the lung mass is, we know the mediastinum is frankly infiltrated. It is N2 or N3 for sure, without any doubts. Having a false positive in this setting is very low. So we can directly place this patient in N2 and or N3 category, and based on the T's, we can assign a stage and we can start treatment. This patient would definitely require a multimodality treatment, a non-surgical, probably a chemoradiotherapy. In this patient, the patient does not have mediastinal lymph nodes on imaging, but the patient has a central tumor. Central tumors have a higher propensity for mediastinal lymph node metastasis than peripherally placed tumors. So this patient, though radiologically is negative, this there's a high chance that this is a false negative. So if you look at it, PET has a very high chance of false negative in this setting, about 25%. In this setting, there is a discrete mediastinal lymph node that if we see here, but this may be an inflammatory lymph node, a granulomatous inflammation, or a post-infective lymph node. So, to call it frankly metastatic just based on PET, we would be erring on the side of false positive. In this setting, CT, for example, has a false positive rate of 40%. Even PET has a false positive rate of about 15% in this setting. On the contrary, in this patient setting, a peripherally placed tumor In a radiologically negative mediastinum, the false negative rates are very low. So, this patient, there is no need to perform an additional procedure to do a mediastinal staging, just imaging will do. But this patient does not require an additional mediastinal staging procedure, just imaging will do, because this is frankly metastatic. This is a very, very less chance there's going to be a mediastinal lymph node metastatic. And two, so in these two settings we can avoid mediastinal staging. Whereas these two settings, in this to avoid a false negative and in this to avoid a false positive, we need additional procedures over and above the conventional imaging modalities of FDG PET to confirm or refute N2 metastatic lymph nodes. That's the aim of doing additional mediastinal staging procedures. So, what are these additional mediastinal staging procedures? The conventional gold standard against which many new modalities were compared earlier is the standard cervical mediastinoscopy conventional. So, a cervical incision is placed, and the special instrument, the mediastinoscope, is passed in the pretracheal plane retrosternally, and lymph nodes are sampled. If we see a paratracheal lymph node, so this is a station 4R lymph node being sampled here. This is the right upper lobe bronchus. So this is a right lower paratracheal lymph node that is being sampled by a conventional mediastinoscopy. This was still a gold standard until very recently, and but this is invasive, requires general anesthesia, and can be disastrous in less experienced hands, and it can lead to complications even in the experienced hands, like bleeding and nerve injuries can be there. We can see that the phrenic nerve and the RLN run close in this area, so nerve injuries can also happen with conventional mediastinoscopies. So to do a proper mediastinal staging, that is to achieve a proper staging with good accuracy, but with a less invasive method, then came these additional procedures. So now the practice differs very widely across centers, across countries, but the ideal right now is to begin the mediastinal staging with a less invasive procedure, that is an endobronchial ultrasound guided FNA or an EUS guided FNA. EUS guided FNA is used only in special circumstances when we are suspecting strongly, when there is radiologically involved station 8, station 9 lymph nodes, and we want to know if they are metastatic or if we want to sample them, a US guided FNA can be used. So, for example, in this patient, in this diagram, we can easily understand with an E-bus. So, we pass a bronchoscope into the trachea. We will be able to sample. It is very difficult to, there is no need to by heart or memorize this table. It's a very logical thing. If we pass a bronchoscope into this, we'll be able to sample upper paratracheal, that is station 2 on either side. We'll be able to sample the lower paratracheal, station 4 on either side. We will be able to sample the subcarinal lymph nodes, that is station 7, and we will be able to sample the station 10 and station 11, the hilar and the interlobar lymph nodes. We will not be able to sample station 3 because in front of the trachea we have the great vessels, and in front of the great vessels is the station 3A, that is the prevascular lymph node, and retrotracheal we have the esophagus, and behind that we have the 3P or the retrotracheal lymph node stations. So that is why with an E-bus we'll be able to sample 5 lymph node stations, stations 2, 4, 7, 10, and 11. If a patient has a enlarged station 8 or a station 9 lymph node on the PET CT, then additionally an EUS guided FNA can be used to target those lymph nodes. So if we combine an E-bus with an EUS, we will be targeting effectively all lymph node stations except station 6, that is the paraiotic lymph node station, which is quite difficult to sample with a less invasive modality. So that is why a special procedure called a Chamberlain procedure used to be performed earlier. That is a left paramedian sternotomy. Sternotomy to uh, sample stations 5 and 6 effectively on the left side. On the contrary, just like a staging laparoscopy, a VATS can also be performed to effectively sample all the lymph node stations. For example, if a right VATS is done, we can easily sample 2R, 3A, 4R, and 7, 8, 9, 10, 11, everything we'll be able to sample. If it's a left VATS, we'll actually be able to sample stations 5 and 6 also. The difference is EBUS requires a special training. So it requires the ability to cannulate the bronchus with the bronchoscopy, that and the ability to do an ultrasound, read an ultrasound. So that is an endobronchial ultrasound. And most importantly, the last step, the ability to identify and target and effectively sample metastatic lymph nodes that are around the trachea, piercing the wall of the trachea. So it's a skilled procedure. It requires special training, and it requires a cytopathologist to be in the same OT where the EBUS is performed, to perform something called as a rapid on-site evaluation, or ROSE, to confirm the adequacy of the slides that are being procured. And it requires a specialist team and a specialized equipment and team. Mediastinoscopy, as we discussed earlier, also requires special skills. It requires a lot of training, and it can be disastrous in less experienced hands. And it relies heavily on frozen section. But if properly done, frozen section, it's quite effective in staging the mediastinum. EBUS, for example, so a patient came to us, this patient came to us, or this patient came to us, we did a PET. There was, for example, let us discuss this patient, we did a PET. He had a central tumor which has a high propensity for mediastinal lymph nodes, but PET wise the mediastinum did not have any enlarged lymph nodes. So we decided to stage the mediastinum with an EBUS was negative. Samples, stations 2, 4, 7, 10, 11 were sampled and all were negative. Now what next? Shall we proceed with surgery directly? The answer is no. Though EBUS has a reasonable sensitivity and a negative predictive value of about 91%, which means a negative EBUS assures us that 91% of the time we are right and the mediastinum does not have any metastatic lymph nodes, but there is still a 9% chance of occult unforeseen N2 disease in the mediastinum. So a negative EBUS has to be confirmed with an invasive modality, that is a mediastinoscopy. So the advantage of doing EBUS is to avoid mediastinoscopy in all patients. For example, the same patient, if we did an EBUS and station 4 lymph node was metastatic, now straight away this patient becomes N2. For example, in the same patient, this may be a T1 or a T1, let's say it's a T1 or a T2 disease, and station 4R was sampled and it is positive. So it is T2N2, which directly places the patient in stage 3A, and you would go for multimodality treatment, probably a chemoradiotherapy or a joint clinic discussion about the role of surgery in this patient being a single station N2 disease, non-bulky N2 disease. All that comes later. That management part we'll be discussing again in a subsequent presentation. But at present, this patient had gone to N2. If the EBUS was positive, all that, so we have avoided an invasive mediastinoscopy in that patient. That is the advantage of starting with a less invasive procedure, that like an endoscopic ultrasound procedures. If the EBUS is negative, we still require to do a surgical staging, that is a conventional mediastinoscopy. This can be clubbed in the same setting as our resectional procedure. So in the same general anesthesia, we induce the patient, we do a mediastinoscopy, send the mediastinal lymph nodes for frozen section, and if they are positive, again we can abandon the procedure because that patient is N2, would not benefit from an upfront surgery. Surgery may be considered in select N2 patients, but never in the upfront setting. So that is the advantage of doing a mediastinoscopy before resectional procedure. So the moral crux is a negative EBUS has to be confirmed with a mediastinoscopy. This dogma was challenged in the last Mediast RCT, which was a large randomized control trial from the Netherlands. So they said after a negative EBUS, if patients are directly proceeded with surgery, resectional procedures, there is, and this resectional procedure will eventually involve mediastinal lymph node dissection, and the mediastinal lymph node dissection specimen will be submitted for the final histopathology report. And the final histopathology report may give us an unforeseen N2. So there was a definite loss of sensitivity in omitting this mediastinoscopy, but this loss of sensitivity or negative predictive value was not very significant. So that was the conclusion of this mediast trial. So, which there are so many nuances, there are so many finer points look in interpreting this trial, because EBUS may be negative due to a variety of reasons, technically, training wise, less experienced ultrasonologists, less experienced uh, people performing EBUS, all that is there. Diagnostic errors can be there, but still, in this ideal trial setting, after a negative EBUS, mediastinoscopy could be avoided without gross significantly compromising oncological outcomes of the patients. So this is the crux of staging of the mediastinum for non-small cell lung cancers. There are some newer procedures like called the